Good afternoon, guys. I'm Dr. Santos. I'm the principal investigator for TexLa TRC, and thank you very much to the Texas Tech University Health Sciences Center palliative team. We are very fortunate to have them today to discuss a burning topic, the topic of the burning bridge to nowhere, dying slowly in the ICU. Thank you very much, Dr. Lux, Dr. Klein, Dr. Abbott, and Dr. Murillo. Being an intensivist, I'm very grateful for all the help that the palliative service, the palliative team renders to our patients in the ICU. I just like to remind everyone that this educational activity is possible through TRC and funding from HRSA. And our TexLa TRC is a part of the National Consortium of Telehealth Resource Center. All right, without any further ado, I would like Dr. Lux and the palliative team to take over. Dr. Lux, you're muted.
Okay, can you hear me now? Okay, thank you very much. We appreciate the introduction and welcome to our little show, which is called the Burning Bridge to Nowhere, which that title, by the way, is not a clickbait title. Dr. Klein and I kind of came up with it collaboratively. Actually, we both contributed to the title because both of them represent kind of two different ideas that come together. The burning bridge represents the suffering for patients in the ICU. And the bridge to nowhere means that some of these patients that are stuck and not progressing in their course, unfortunately, experience a lot of suffering along with their loved ones as well and the team. And so we want to explore those issues that come around suffering for very little gain in some situations in the ICU. So we're going to go ahead and get started with our presentation, and we're going to have a little different format this afternoon. We're going to have a few little factoids represented at the very beginning of our presentation, and then we're going to move into our case presentation that sort of demonstrates the issue at hand, and then also some remedies that we found are useful based on our work on the palliative care service. And I just want to mention some of the people on the team and panel here today. We have Dr. Kelly Klein, who is Associate Professor of Family Medicine and Head of the Palliative Medicine Fellowship here. We also have two palliative medicine fellows, Dr. Abbott to my right, who's a palliative medicine fellow and internist, and then Dr. Murillo to my left, who's palliative medicine fellow and family medicine physician. And also on our team, we have Dr. Stephen Gates, who is participating in the call, and Amy Blazik, PA, and Sandra Sherparel, who's a nurse practitioner, all part of our inpatient palliative care consultation service at TTU-HSC for the University Medical Center. So thank you, and thank you also the coordinators helping out here today, Max, Jimmy, and Laura, who is helping out for this broadcast. Thank you very much. So please, as typical now, I know everyone's a Zoom expert, but mute yourself until you get, or keep yourself muted until we get started with the questions and such, and input session. The best way to probably participate is through the chat box, and we'll be monitoring the chat box for any questions or concerns or comments. Also, we would like to let you know that there's a valuable CME available at this, and I think we're going to be scanning the QR. You can scan the QR code with your phone, or go to the website and claim credit for this meeting at the end of the meeting if you participated. So thank you very much for participating today, and also hopefully you will claim your CME that you have won. So going through this, in terms of disclosures, unfortunately, neither Dr. Klein nor myself have any financial disclosures and conflict of interest. We would love to have some, but we didn't have any to report today. We apologize for that. And we would like people to hopefully come away with this understanding, not only that this issue of being stuck on the burning bridge does not just apply to the ICU, but also it applies to anybody with serious illness who has disease progression, is suffering despite active aggressive treatment. And this really applies to multiple venues of care, not just the inpatient setting. So there is the burning bridge. And just for clarification purposes, the item that the gentleman is holding is not a weapon. It's actually a chainsaw. He's a firefighter. So just to clarify that, we're not advocating any sort of violence here. And thanks again to our 0 billion followers that are out there. That number keeps growing. It was 0 million in the past, and now it's 0 billion, and we're very proud of that. Okay, so suffering without meaning is our common theme here today, and we said this applies to not only the patient, but also applies to family members, loved ones, and the staff, as well as society as a whole, when people are being treated for extended periods of time in a very difficult situation. So basically, as I mentioned before, the burning bridge is suffering, and the bridge to nowhere is not a political statement. It's basically a representation of the fact that the prognosis is very dismal. And it does also have, I guess, some financial implications as well for society. So now we're going to turn it over to Dr. Murillo for the ICU patient experience.
Thank you, Dr. Lex. Okay, so the ICU patient experience, something that we often say, yes, we know about, but can often be overlooked. So patients and families report memories of having pain, anxiety and panic, nightmares or distress, and trouble breathing. Even these perceptions that patients experience were correlated, or their perception was actually correlated with their pain. What the studies show is that family members actually have their ratings of pain and anxiety were actually really similar to nurse pain assessments on behavior scales and with sedation scales, but the actual patient memories were much higher, were actually moderate to severe compared to nurse and families. So even though their pain may not have been adequately addressed, or some of the other symptoms they experienced, families and patients did have satisfaction with their care. So they did feel that nursing staff was able to address their needs. However, this was also based on how much time the healthcare provider actually stayed with the patient at bedside. And then second to that was family present at bedside. Let's see, so what really exacerbates these pain and other symptoms or frustration with communication barriers. And with the increase in communication barriers, there was also an increase in distress. And other methods such as lip reading and message boards are actually found to be in use really inconsistently in typical ICUs or majority of ICUs. Okay. All right, so, sorry, yes. Next slide. Common experiences of the ICU. So changes in body functions, of course, patients experience, but change in body function and body image, and that can, and as well as the lack of control over their body and its functions, leading to vulnerability and anxiety due to, in anticipation of further deterioration. And of course, there is the physical nature of being tied down to tubes and lines and sometimes restraints as well. This was, as well as thirst being a frequent and unpleasant experience. And so the environment in the ICU. ICU can be very noisy. There's a lot of unfamiliar sounds, and it can be very scary, to be honest. They felt that they were getting, patients often felt that there was a lot of distress hearing what was happening outside of the room to other patients, whether they had cries or their alarms or bells, whatever, were going off. And so they felt that they had a lack of privacy because of that intrusion. And it made a very big difference when nursing staff are able to try to minimize those distractions. And there was a big difference. The experience of time, usually that it passed slowly, and that they lost track of it. It was easy for some patients to lose the distinction between night and day, and that led to feelings of helplessness, confusion, and of course stress. Reality. Reality could be diffuse and unreal. Sometimes they have difficulty remembering and understanding the situation, paranoia, and feelings of being trapped. This also made it difficult for them to distinguish between real and what was real, and that also affected communication with health teams. So the experience of sleep was, of course, interruptions of sleep, difficulty maintaining sleep, initiating sleep, which led to further stress. Let's see. And then, of course, with that, good and bad dreams, depending on each patient individually. The experience of being dependent. So a lot of these times, especially if it's a sudden onset illness, trauma, etc., being dependent and loss of independence led to patients feeling weak and helpless like a child. They felt that they were a burden not only to the staff, but also to their family. And then also being unable to toilet on their own was especially disgraceful and embarrassing. Not being able to breathe or get enough air, that was in response to being connected to mechanical ventilation, and that constant feeling of dyspnea was ever present and scary, which led to anxiety and panic and difficulty to relax, as well as the physical sensation of the tube being a source of pain. The experience of suctioning was very unpleasant across the board in several meta-analysis of patient experiences, especially if nursing staff were applying strong force, which may or may not have been necessary. They felt relief after having suctioning when appropriate, but the actual procedure itself is very painful. Significant information involvement. So often patients feel that they had a lack of information about their situation. When they did get some information, like what was about to happen to them or what they were doing, they did feel a little bit more safe and a little bit more like their dignity as a person was valuable. When that wasn't readily available, it was the lack of information and involvement led to insecurity and powerlessness. Also, there was a significant amount of hope and longing, and that could be longing for being out of the ICU, back at home, out of bed, and different. And that goes along the lines of sadness and anxiety. And then also the importance and significance of relatives. So patient qualitative studies have shown that it's imperative to have not only a person present, whether that is a nursing staff or any other staff, and family members was also really important. Now, if the person at bedside was unable to care for the patient, like if they created more drama or if they themselves are really stressed or anxious, then that actually was detrimental to the patient experience. Okay, next slide.
It's not advancing here. I don't know
Oh,
why.
there you go. Okay, so some of these experiences, though, were not unique to just being on a ventilator and could be seen across the board for some ICU patients, but did not specifically mean if you were in the ICU, you were going to experience all of these. It's a very much on a case-by-case or situational basis, and depending on what brought the patient in. So anyway, there was also studies showing that non-invasive ventilation could also be possibly a traumatic experience, even leading to PTSD. So the cognitive and affective attitudes towards non-invasive ventilation would markedly deteriorate during the use of non-invasive ventilation. Let's see, so a significant proportion of patients who undergo NIV actually would regret having allowed that treatment to be given. And so prior beliefs like dyspnea, relief, increased independence were often contraindicated by the actual experiences, which was persistent or worsening dyspnea and the mask pain, discomfort, limited communication, of course, again, lack of independence. Those were the actual experiences. And then positive elements such as removing the mask were also reported. But the sum of all this actually led to an ambivalence towards the treatment, and ambivalence in other studies have shown to be a predictor of future treatment refusal. So if they don't feel like it actually is worth going through this procedure, or it's not something that the patient wants to repeat, then likelihood of successful use was not going to happen. Anyway, next slide. Okay, so like I mentioned before, the presence of family members is important to the ICU experience, or is an important part of the ICU experience. And so family of caregivers often experience more than one symptom, usually psychological, with a family member in the ICU. So some studies have shown that it's one pervasive or another pervasive symptom, but new data is showing that it's actually 7 to 9 co-occurring symptoms, with worrying being the most severe, pervasive, and distressing. The fact that the patients were having symptoms was not as distressing, but the severity of the symptoms that they were experiencing was most concerning. So let's see. And so again, that leads to a greater psychological burden that was noted. Okay. Next is actually, new data has been showing that the younger caregivers were having more symptoms compared to older ones. It was assumed that older caregivers were actually more likely to experience negative outcomes because they had more comorbidities, et cetera. But it was actually that the younger ones who had less life experience and would have a higher incidence of depressive pattern of symptoms. Spouses, of course, are usually a higher majority. They make up the majority of caregivers, and then it goes down the line from adult parents, children, etc. But the spouses did experience more symptoms. Let's see. So we actually do need to look a little bit more into caregivers' experiences, because it seems like they're there, but then they're not there when we talk about the ICU patient's overall care. And so really paying more attention to the caregivers, I think would actually help a team-based approach to ICU patient care.
Okay. So I hope thank you, Dr. Maria. That was what we're doing here is building a case for, as you can tell by Dr. Maria's section here, that patients have a lot of energy tied up in this thing, in being a patient, and there's a lot of suffering that goes along with it, a lot of distress for both the patient and family members. And I think what COVID-19 did was bring to the forefront that there's a lot of patients out there that get in this position where they're stuck in the intensive care unit after receiving maximal medical therapies, and yet they're not really advancing or progressing. So all these burdens are basically being expended on behalf of the patient and through the patient, yet with, in some cases, especially in the cases of advanced respiratory failure, very little gain. And so we just want to paint a picture of the type of suffering that's going on. And so now Dr. Abbott is going to be talking about some of the realities of ICU life in terms of the statistics for and truths for care.
So this is a little bit less experience and a lot more numbers is my section. So very kind of hard, unfeeling numbers, but so some truths about the ICU. So this amazed me. 20% of Americans will die during or shortly after an ICU stay. So that's 1 in 5. So this is something that affects a large proportion of the population. And in addition to that, at any point in time in America, there are approximately 100,000 previous ICU patients who survived, quote, the ICU, but are still dependent on critical care. So they could be in a nursing home, they could have a feeding tube, they could still be on a ventilator with a trach, things like that. So they're still dependent on very high levels of care, even though they, quote, survived the ICU. And so we can't, forget these people just because they left the ICU doesn't necessarily mean that they aren't still suffering from that, not from the care they received there, but from their illness that got them there in the first place. Only 5% of all admissions to the hospital end up in the ICU, but ICU costs account for, monetarily wise, account for 20% of hospital expenses and 1% of the entire GDP of the United States. And I did the math, and that's more than $200 billion a year. So in patients who required mechanical ventilation for more than 12 hours, the overall overall mortality was 30%, and was much more dismal in patients intubated for ARDS than for patients with COPD exacerbation. This study did not delineate further than that, but just kind of something to keep in mind. If you have a patient you're intubating for ARDS, they are actually more likely than not to end up dying in the hospital from, during that stay. So if they require it for more than 12 hours. So this actually doesn't even include patients who die within the first 12 hours of intubation. And then the 6-month outcomes of patients who spent more than 3 days in the ICU and were on mechanical ventilation for 2 days or had vasoactive infusions for more than a day. The survival at 6 months was actually only 56%. And this is patients who survived the ICU, who were discharged. Survival at 6 months was 56%, and only 30% of those patients returned to their original baseline before their hospital stay. I thought it was interesting that just a little over half, 62%, were able to report normal cognition. And obviously there's, related to mechanical ventilation, there's reasons that their cognition may have been affected, but it's just something to keep in mind when we're keeping these people on ventilators, is that they are not all that likely to return to their baseline of functioning. And, whether or not that's important to them is a discussion we need to have.
And just to clarify, Dr. Abbott, that data that you just presented was on for all comers in the ICU, not necessarily for COVID patients that end up in the ICU, which is actually the numbers are probably even worse.
Right.
At this point in time.
I tried to keep my information non-COVID related, although it was difficult because there's a lot of COVID studies, but just so that it would be more generalizable to the entire ICU.
Right.
For patients who end up undergoing tracheostomy, 74% of them survive to discharge, and only 53% are alive at 1 year. And then this study also looked at the different ICUs. So best outcome was in the surgical ICU and worst outcome was in the medical ICU. Interestingly, 7% of patients died within 1 week of receiving a tracheostomy. So just something to consider. That's, close to 1 in 10. Well, 1 in 20-ish.
In Texas, that's how we call that 1 in 10.
I can't do the math that fast, but it's 7 out of 100, obviously.
1 in 13, but okay.
So the measurable impact of ICU palliative care, as discussed, and some of these were meta-analyses and some of these were individual studies, but it actually was able to reduce the medical ICU length of stay by 45% if the ICU consulted palliative care early on in the ICU stay. So there's obviously a significant reduction in MICU length of stay, and that happened without changing the mortality and without changing the discharge disposition. So these patients ended up dying the same amount of time and going to the same place when they left, if they lived, even though their ICU stay was much shorter. So, and monetary wise, it has shown early consult of palliative care has shown a decrease in the average ICU cost of 15% for those who survive their hospital stay and 22% for those that die in the hospital. Again, without changing the mortality. So there was a project where an ICU palliative care initiative was instituted in 6 different ICUs. And these were kind of the initiatives. And these are really things that would be goals for any ICU, but unfortunately don't often have the time to do these things. And so this initiative was put in place, and the initiative said that by the first day of the ICU stay, we would address all of these things, including managing pain, assessing pain, finding out their code status, things like that. By ICU day 3, we would offer spiritual support and social work. And by ICU day 5, we would have a family meeting. And so this is the data before and after these initiatives were instituted in these 6 ICUs. And so as you can see, for example, an interdisciplinary family meeting happening by day 5 was only happening in 25% of cases. And after the initiation of this model, was happening in more than 80% of cases. And so we understand that the time constraints on critical care units may prevent us having a family meeting on day 5 for every single patient. But in these ICUs, basically it was put into place that we would consult palliative care early on so that someone would be able to have that family meeting and would be able to devote that kind of time. And so all of these are, as you can see, are worthwhile initiatives that we should be trying to get in our ICU patients, especially those that are there for more than 5 days. And it's just interesting to see, maybe not everybody needs to have this exact same kind of model, but it was interesting to see that when you put this in place and made it a protocol, that it really did improve the likelihood that these different initiatives would be undergone. Mm-hmm. And so here is listed kind of a summary of a bunch of different studies based on palliative care consultation in the ICU. And these are, there's numbers, they're cited at the end if you want to look into them. I did. They're real. So it was able to decrease the hospital length of stay, like we said, decrease the use of non-beneficial treatments, increased family satisfaction, decreased family anxiety and PTSD, and decreased conflict over goals of care. It was actually cited in a lot of articles, especially between RN and medical primary team. Which often the RNs would have a lot of concerns that the primary team didn't. And the longer the patient was there, the more those would diverge. Increase symptom assessment and patient care, and decrease the time from a poor prognosis to reaching comfort-focused goals.
Okay, thank you, Dr. Abbott, and thank you for that plug for palliative care consults in the hospital. I'm sure that's not a self-serving thing, but anyway, but basically, one of the reasons secret sauce of palliative care is time. And unfortunately, when we don't have time to talk to people, we can sometimes prolong misery, prolong hospitalizations, and prolong implementation of goals of care. So that's really the role that we fill. That's why one of the reasons that we exist and how we can help out. So now our next section is going to be the case presentation, and Dr. Kelly Klein is going to be presenting the exemplary case.
Yeah, so this is an actual case that the palliative team had, and it's a case of a 77-year-old female who was admitted to the MICU 38 days prior with COVID-19 associated pneumonia. And she had ARDS, was intubated, was on mechanical ventilatory support day 34. And she wasn't progressing despite maximal treatment. And her COVID infection had resolved about 14 days ago and was still on near maximal ventilatory support with high pressures, high FiO2, and high FO2 precluded tracheostomy. And now she's on pressors, norepinephrine, and having non-oliguric AKI, worsening LFTs, and suspected COVID-related encephalopathy. And she also had an adynamic ileus, was on TPN, and the renal team was considering CRRT. And so we had been consulted twice during the course for goals of care, and this was the third time in her course that we had come to see the patient during this hospital stay. And so past medical history included type 2 diabetes mellitus, which was poorly controlled, NASH, cirrhosis, lupus, hypertension, and hyperlipidemia, sorry. She was a non-smoker and did not use any substance disorders. She'd been widowed for 5 years and was a retired teacher. She had 5 adult children, no designated medical power of attorney, no advanced directive documents had been filled out. and no, or that were on file. And she enjoyed taking care of her grandchildren, cooking for the family, crocheting and knitting. And she had been seen frequently by her PCP for UTIs, uncontrolled diabetes, and lupus flares. When she was admitted, it was for shortness of breath and fever and hypoxemia. She was intubated on hospital day number 4 and transferred to the MICU, of course. On hospital day number 12, that's when she had for a pleural effusion on the left, she had a chest tube placed. And on day 15, she was still failing weaning trials. Day 17 to 22, she was noted to be in septic shock due to MRSA. On hospital day number 23, her sedation was removed and she had no purposeful movement. 3 days later, she's noted to still be in AKI, worsening LFTs, and in fact, her MELD score was 35, and that equates to a 52% 3-month mortality rate. And so on exam, she's elderly female that's intubated and restrained at her wrist and visibly jaundiced and unresponsive despite the sedation being turned off. But she did respond to pain. So her blood pressure is 94/60, pulse of 110, respiration's 22. So her sclera were ecteric and pupils equal and reactive to light. And she had an NG tube in place. She had an OG tube in place, a number 8 ETT tube. Her lungs were fine rails diffusely, heart regular rate. Well, she was tachycardic actually with a regular rhythm. Abdomen was soft and benign. She had a Foley and a rectal tube in place. And neurologically, she would withdraw to noxious stimuli, but had no purposeful movement. And she was just no focal deficits. And so a CT of her head, it showed, and this was without contrast, she'd also had an MRI of her head, which showed mild atrophy, but no acute CVA or bleed or mass. And abdominal ultrasound showed the typical cirrhotic liver changes and no gallbladder, small amount of ascites. So on her CBC, her white blood cell count was 10 and hemoglobin was 10.2 with a hematocrit of 30.4, 117,000 platelets. Her sodium's a little low at 132 and her potassium is normal at 4.5. The BUN was 64 and her creatinine was 2.9, so which calculated her creatinine clearance to be 21. So blood cultures and urine cultures were done, and the most recent ones, 4 groups of those have been negative ×4. Anyway, any questions about her case?
So basically, we have a lady who's been in the hospital for quite a while, over a month, intubated, not progressing, and some evidence, at least indirectly, pointing towards this COVID encephalopathy. You saw what her life was kind of like a little bit beforehand, and now she's in this position where she's unable to move forward, and she's stuck on the burning bridge, so and going nowhere. So this is our dilemma, which unfortunately was extremely common during the last year, but it's also common before that, where people stabilize initially. We do a good job of stabilizing people, and then they're non-progressive. And so I think the COVID just kind of magnified that a little bit, because their outcomes were even worse because they couldn't even get to the point of tracheostomy. And like in this case, where their PEEP settings were so high and their FiO2 was so high that they really couldn't even go for a tracheostomy. And so their options for care were limited, even if they survived, and they did survive the initial infection, which is unfortunate. After going through all that to get to this point, we're still in a very, very desperate and bad situation. So any comments about that? Doctor, just looking at the chat box, Dr. Santos mentioned a couple of things about the discomfort with suctioning. And yes, it's done quite often and quite routinely. And in fact, family members kind of tend to expect it after a while, and they want to get in on it, but it is a very uncomfortable thing. I don't know how you could make it better outside of aerosolizing, morphine or lidocaine prior to doing it, but I don't think that's going to be a standard of care thing.
One comment on that, actually studies have shown that even patients who are sedated in the ICU, if nurses explain what they're going to do, and Dr. Murillo touched on this, if nurses explain to them what they're going to do, it causes significantly less distress. So if you explain, we're going to suction this patient, we're going to suction you. It's probably going to hurt for a while, but it will make things better afterward. Then they're not so shocked by the initial pain, and they still get that relief. So.
The other 800-pound gorilla that's in the room here with this whole situation with COVID, of course, has been the lack of visitation privileges. So what that does is it creates increased stress and anxiety, not only for the patient, but for all the loved ones. And so then they start imagining things that are probably not happening, like the patient's comfortable. They're not really seeing the day-to-day stress the patients are undergoing. So they're making assumptions that everything's fine because they're safe, they're in the hospital, they're plugged in, and everything's wonderful. When unfortunately, that's not the case, and they're not there to witness and talk to the nurse to find out what's been going on. So.
Just for clarification, all of the information that I had presented was pre-COVID, updated from some of the data that is presented on CAPC. But yeah, this is assuming everything was normal in the before times.
Yeah. So, and the CAPC acronym stands for the Center for the Advancement of Palliative Care at capc.org, capc.org. And it's going to be listed as a reference. So just to bring you up to speed on this patient again, we had 2 prior family meetings with our previous involvement with this patient during this extended hospital stay. And this was the result of the meetings. One is that there were 5 adult children, and they had to kind of reach a consensus, but they were in consensus most of the time. And the overwhelming theme that came through was, A, she's a fighter, and we hear this a lot. She's a fighter. She's been through harder times before. She's had all these multiple medical illnesses. In fact, this patient at one point in time was hospitalized for, I think, 3 or 4 months in the hospital and survived that hospitalization. And they thought that made the patient bulletproof, I guess, from here on out. But unfortunately, it was a completely different thing. I think it was a sepsis episode from gallbladder situation, but it was not at all related to COVID, of course. And it was a few years earlier when the patient was in a little bit more robust physical condition. So that theme came up. She's a fighter, and we hear this a lot on the palliative medicine service from family members, and also that she's been in worse situations than this before, even though there's no 2 situations that are equivalent. This one, though, over time, the patient should have been proving to everybody that she's not really advancing, unfortunately. And then also there was this very difficult issue about, we believe there's going to be a miracle, and we're very faithful people, and we believe there's going to be a miracle. And so we're going to talk about a little bit of that and how we can kind of navigate some of those issues. And the last item that they were looking at, and this was not intentional, but it happened. And so we're going to report it because it did sort of make the medical decision-making, or the decision-making by the family, complicated things, is that we had an MICU attending that was a temporary attending, and they had not really spent as much time with the patient, but in their communication with the family, this covering attending mentioned to the family that all of her problems were essentially reversible, and including her end-stage liver disease, which was kind of a mistake. And I think that there was maybe some of the lab markers could have been reversed, and I think that's what he was referring to, but the family took it as they can fix this problem very easily in the liver, which is unfortunately not the case. I'm not throwing anybody under the bus, essentially, but I think it was probably a communication problem and how it was perceived, but it did complicate matters in this situation, and it's not uncommon that miscommunication is part of the problem, and it causes some foot dragging and delayed decision-making, unfortunately. So any questions about that, just fire away, put them in the chat box, and I'm going to keep going through with our little rant. And so we had 2 previous family meetings. The third one, we all got together, meaning everyone on the medical team and then we got together with the family, and we had a new strategy of basically having a unified front rather than piecemeal delivery of information. And we had a final family meeting. So this section, we call it getting off the burning bridge, or getting off the bridge, and how we were able to do that in this particular situation. And this is a common set of tips that we use inside the hospital to make it work. A lot of these things are commonly taught in terms of how to set up a family meeting. And so there's a lot of familiar themes here, but we're going to explain a couple of these things. I think there's some useful points in them. So basically, we set the setup, the environment. We get a large, quiet room as much as possible. Have people there, mainly all the decision makers in the family. Okay, so that's the surrogates, and if there's any influencers, quote unquote, the people that might be family is looking to, either on the medical side, on the medical team, or within the family unit or the loved ones, associates of the loved ones. We want to get all the influencers and decision makers in the room at the same time as much as possible. Now, there are restrictions to how many people you can have in a room, certainly during these times, but ideally that's what you'd like to do. Also, on the medical team, everybody that needs to be there, including the MICU attending, someone to speak authoritatively about the medical situation, any relevant consultants. And most importantly, I think this was one of our best things that we did, was because we weren't really doing this routinely, is having the nurses come in that had been taking care of these patients and providing their testimony and their witness at the bedside. That was a very, very helpful, useful thing. And I wish we do that a lot more often. These people are always tied up doing a lot of other things, so it's hard to pull them away. But gosh, I love it. And most of them love to participate in these meetings, and they love to be able to share their opinion, because they too are not only firsthand witnesses to see what the patient's going through in these situations of some borderline futility, but they're also helping to resolve the issue. And respiratory therapy, and sometimes also can speak to some of the distress the patients are going through. The other thing that we did that was important was, before the meeting, we all got together and understood that we would be offering a prognosis, and actually talking about prognosis, which is one of the biggest mistakes is made in these meetings, is people not being willing to offer prognosis, and that we would agree on basically what our viewpoints were, so there were no major conflicts or conflicting information that would make the family unsettled. So what we mean by that is that we weren't trying to sort of homogenize our opinions. We all had our own opinions that we respected, and everybody had their own areas of expertise, but we wanted to present a somewhat unified front, at least in a general sense, about what we thought was the future moving forward as best as we can tell. And that's really important, because sometimes if you see the patient separately each time, like had happened earlier in the hospital stay, every attending or every service renders their own opinion from their own narrow perspective, and they're not willing to give an overarching broad brush view of what's happening. And that's really what families need. Yes, they need details, but they also need it. And they need specifics, but they need the big picture and what this is really going to look like, and for people to stick their neck out a little bit about prognosis. Okay, so we review.
Dr. Santos also put on the chat that, you mentioned having RT, but also having the social worker and chaplain there too.
Yeah, social work especially, because some of the disposition, if a patient would survive hospital stay and they'd have to still be intubated or still had dialysis, in some cases they'd have to be literally sent to another state to go, like Utah or other places like that, Louisiana. They had some very limited options for care that was very, very difficult for not only a patient, but family. So this is the strategy. This is sort of the order that we followed. We reviewed the patient's course in the meeting. Once we started, everyone in the room, we reviewed the hospital course. We didn't jump right into the prognosis or the goals of care at the very beginning. We allowed them to ask questions about the hospital course and discuss in detail any questions or concerns they had about the hospital course. Then we requested information from the family, again, before jumping into decision-making. What was the patient's life like before? What did they enjoy doing? What were their likes and dislikes? What were their interests? What's their views on functioning independently or not? Could they accept help? Are they very independent people? How do you think this illness impacted them so far? So try to get this all from the perspective of the patient. The goal here is to try to have the patient speak at this meeting, which is the hard part, because loved ones are always wanting to subconsciously or consciously, basically put their will in front of the patient sometimes. And that's not a negative thing, but it's a protective and paternalistic thing in some ways, but sometimes it keeps them from actually advocating for the patient themselves. So we wanted to ask first, what would the patient say if they were here in this meeting? What would they do? What was their opinions of these things? What if they could be here, what would they say? It's very important to elicit that. Okay. Then after we got all that input about speaking for the patient, then we would talk about prognosis. And we did that in probabilistic ranges and extremely qualified, meaning that we admitted that we were wrong, that we can be inaccurate because we're just humans. But we know based on experience of other people in these situations, for example, a COVID patient that's intubated for more than 7 or 8 days, more likely than not, they're not going to survive the hospital stay, and they're going to die a very miserable death if they're not on comfort care at the time that they pass. So we wanted people to know the truth of that. Even though we're not 100% sure about the future, we do have some information to share with them, and we need to be honest and straightforward about that and communicate in very direct ways and not be too fearful about providing information that we think might somehow crush hope or hurt them. Then we also ask the family members what the patient's view of the loss of independence and permanent loss of independence or functioning, body functioning, how they would perceive it. Some patients don't have a problem with losing functions, various body functions. Other people, it's their whole life, and they don't want to do it. I've had somebody say to me before, if I can't hold my grandchild and pick them up, I don't really want to go on like that. I don't want to be in a horizontal in a nursing home bed the rest of my life, if that's what I can't do. Okay, and it's especially worse now with all the restrictions for visitation. We reviewed the burdens of ICU care, and again, the nursing staff was very helpful about validating that for family members, and then discussed miracles and our view of miracles. And miracles come up a lot, and I'm going to talk about that in a second. And then we discussed the comfort care plan and compassionate withdrawal option, and we allowed family members to sort of talk about and ask questions about the different options out there and explained all that before we asked them to make a decision. Lastly, then we basically allowed them to have some private time after our meeting to come to get to grips with the answer if they didn't already have an answer for us during the meeting. So just a little rant about prognostication, okay? It's one of the 3 critical things we're called to as clinicians to do. I mean, we're called to diagnose and treat, but offering a prognosis is actually one of the 3 cardinal functions of someone in healthcare, physicians and nurses and PAs and NPs. That offering a prognosis is important. And even though it's imperfect, there is a lot of information out there that can be delivered to patients. There's online calculators for different organ system problems or malignancies. There's all kinds of information on ICU patients in terms of prognosis. So we can be a little bit honest, but as healthcare people, we sometimes think that we're going to crush hope and that we shirk our professional responsibility that we have to do this. And this is important because families need this information for their own decision making, and it can be delivered in a very kind way that's not harsh, but we need to be able to give them some hard, difficult pieces of information like this prognosis. So the next little mini rant is about miracles and how do you handle a miracle situation? And I'll be curious to see from people out there, all the participants, how they handle the miracle question. Here's one approach, okay? One is it's okay to acknowledge, and you should acknowledge and affirm a family's belief in miracles. We can't, who are we to basically say that they don't exist or that they shouldn't believe in it? Sometimes family members believe that because we're grounded in science a lot, that we don't have any room in our space, in our minds, in our hearts to basically believe in miracles. And that's wrong. And it's okay to share your own belief with that, but basically to avoid disparaging or discounting miracles that they can exist. However, one important thing, this is the thing that I think is the most important discussion in miracles, is that miracles, if they emanate from a higher power or somewhere in the universe, they don't depend on us, or they don't depend on the patient and their loved ones to happen. They're going to happen regardless of timing, regardless of the actions of the patient or inactions of the patient or the loved ones or the family or the healthcare system. So that's involved in the team that's involved in taking care of the patient. Miracles don't depend on us or them. That sort of should unburden the family and their perceived anticipatory failure of, if they don't believe in the miracle and that it can happen, then basically we need to not, we need to keep going and continue the suffering. And even though, because a miracle might sneak in there, if a miracle is going to happen, it's going to happen regardless of the timing, of our decisions, of our actions. Okay, that's our view of it. I'd love to, again, please load up the chat box on whatever you think that would be helpful for the miracle. Let's see.
Yeah, Joyce, Dr. Naughty brought up that there's that wonderful article called where it points out the Amen protocol, and that's out there. And then we can send you a reference for that. I love that article though. And then the fact, hope, reality model. The fact is this. We too hope X, but the reality is this.
Yes.
Model also.
We wish it was different. We're all hoping for a good result, but this is what we're dealing with. And we may not predict the future well, but we do have a track record of the recent past and a trend to go on.
Yeah. And then talking about, the prognosis we give them is based on our medical knowledge and experience rather than what we hope will happen. But it is based on that reality of this is what those numbers are.
And also to leave ourselves an out that if something good happens, we're going to support it.
Yeah.
If something really, if there's a dramatic, spontaneous turnaround, we're going to support it. We're not going to abandon the patient because we already set a plan in place to go a different direction.
Now, Dr.
So-
Gates may have a comment on miracles.
And Dr. Dawson also.
Okay.
Well,
Well, how about it? Go ahead.
yeah, so yeah, I appreciate, no, I agree with what you said, and it's certainly a common sort of thing that we deal with. The two things that we hear most commonly are the fighter rhetoric and the miracle rhetoric. And, sort of my approach to that is, first of all, I think it's important that, again, like Dr. Lux said, that you acknowledge the fact that you can see that a belief in a miracle is very important to the family, and that you are supportive of that and so forth. But again, as Dr. Lux said, I just emphasize that the information we're giving to you, we're not giving to you as clergymen or prophets. We're giving this to you as physicians, and that's what we have to base our decision on. And this is on the basis of our knowledge and our experience and our data. And as you mentioned, that a miracle is by definition something that's beyond the natural realm. And I sort of point out that all of these machinery that are keeping this patient alive, these are not divinely inspired things. These are technology. And I kind of point out that, human beings initiated this technology on this patient, and we're now saying that this technology is no longer helping. So that's sort of the way I try to guide with that discussion. But it is, just to point out that we can only address the patient as physicians, while at the same time being respectful of their beliefs.
Yes.
Um,
I'd like to
May I make?
Okay, sorry.
Oh no,
Yeah.
it's Catherine Ronahan. I'll wait my turn. I couldn't tell how to.
Go ahead.
Go ahead. You're on.
Yeah, you're on.
Okay, so I totally agree with Dr. Gates. However, I might slightly disagree about the technology can in and of itself be a miracle, but I've now seen a miracle twice since I've been here, and I think all of you who were involved in her care, she was, made comfort care appropriately, went to the GTU, was there on the floor, literally with documented O2 saturations in the low 50s for 4 days. And then she woke up and said, what in the living name are you people not doing? And she had had a whip stitched open abdomen for about 10 days. And that woman is now awake. And I know you guys will, some of you will certainly remember her, but anyway, that was, literally that was a miracle.
I think anyone who's been in practice a long time has seen things that they can't explain that would go with that idea that there are miracles. I've certainly seen them. I agree with you, Dr. Ronahan. I think they're out there, and I think we need to leave space for that in the discussion. The other thing that we need to, I think, keep in mind, and we try to bring it up even though it's hard to really convince people of this is that when we have these meetings, we're not trying to get people to make a medical decision. We're trying to get them to make a philosophical decision on the care of the patient. And we hope that they trust us about the medicine, that they trust us that we did everything we could to get the patient through this, but it just didn't work out. But again, I think it's always wise to leave, and this Dr. Ronahan's example is a great example of leaving yourself a little bit of space to say, I admit we can be wrong. Not everything's perfect. Not everything follows a script, and we're going to support it if it gets better. You know, if that's what we're going to do, that's okay. So yes, that's it. And I like your little avatar, Dr. Ronahan, too, by the way. Okay. All right. So
Did you have a?
yeah.
All I was going to say is I think in the goal of all these protocols, and I think very consistent with what Dr. Lex was saying, is your goal is to avoid that adversarial position. That's going to accomplish nothing. And to only speak, let me speak to what I know from my medical information, not trying to discount a miracle. And at the same time, I think one of the most valuable people to have in the room, if you anticipate this, is a very palliative trained or palliative informed chaplain. Can be very beneficial in picking up the ball
Yes.
when the family says it kind of perceives you as countering to their faith. I can tell you a good chaplain has been one of the best people on the team for many of these situations.
Right.
Yes.
Exactly. So
And
that's a
Laura
good
Lappy
comment.
put up a couple of references in the chat box for the articles that Dr. Noddick had referenced about the Amen protocol. And then another tool from one of our palliative colleagues about when patients wish for a miracle, it's a tool that helps medical staff reply. So awesome.
And I think also when we have trouble breaking a prognosis that is not all that optimistic from what they would consider, I think it's important to remember that we're not crushing hope. We're avoiding giving false hope.
Yeah.
So that it, you know, in our own minds, we don't want to necessarily tell the patient that, but just reminding yourself that I'm not trying to crush their hope. I'm just trying to not give them an unrealistic and false hope.
Yeah, and for the people that are worried about crushing hope by giving bad information, we can't really crush hope. That hope is between the patient and their God, or the patient and the universe and their family in the universe. We can't really crush the hope. We can give information that they might not embrace or they may not like to hear. But we're trying to be honest, and if it's delivered in a sensitive way, I think it's really important to help with decision making and to limit suffering. I mean, no one knows the future for sure, so nobody can. But that doesn't mean you hide behind that and not try to offer some kind of reasonable insight about what you think the trend is going to end up as. You know. So anyway. And yes, and I think and what's interesting is that you don't have to have necessarily a spiritual person there who is exactly lined up with that person's view on, or that specific brand of faith that they have. It's nice if you can, but even having someone like that, a voice of authority, like a consultant in a brain case, you had the neurosurgeon or the neurologist there. People do respect it and they do appreciate that input. Our biggest problem is just getting a room big enough for all these folks to get into. Yeah.
Especially during COVID.
Yeah. So any other comments or questions? That was really some good commentary on there in a very difficult situation. Well, I will wrap up the case by just telling you that after the third meeting, we finally did reach a consensus and did move towards compassionate withdrawal from ventilatory support in this very battered, unfortunate individual that had been there for a very long time with a lot of suffering, and I think ultimately it worked out, but it took a while. And part of the problem was also on how we approached it in this piecemeal fashion rather than being unified at the very beginning when it looked like the trend was going to be obvious. At least at the first signal could have been at the time when the patient was failing ventilatory support weaning trials and not a candidate for tracheostomy. And then certainly when there was 3 weeks in, when there was no chance really based on our suspicion of COVID encephalopathy, that this individual was going to have a meaningful neurological recovery. And unfortunately, this COVID, even though it's a diagnosis of exclusion to some extent, COVID encephalopathy is a very big thing that's happening to people that survive their respiratory problem, and yet they're not going to be able to function. And that's as an adult like they were. And that's a very sad, sad situation. But anyway, we appreciate everyone's participation and encourage you to fill out your surveys to get the CME. And thank you for participating with us today. Bye-bye.
Make sure to put the QR code.
Dr. Lux, before we proceed, we would like to present to you something for your time and effort. We have you a challenge coin, courtesy of Rural Health. Thank you very much, everyone, for attending this seminar. Really enjoyed the conversation, and make sure we get involved the palliative team earlier on. Thank you very much, and good afternoon.